Okay, and with that, we move to the last talk of today's symposium, it's a great pleasure to present Dr. Harriet Kluger. She's a professor of medicine and director of numerous things here at Yale, but besides everything, she's just a great physician and a great investigator, and it's a great pleasure to have you here. Thank you, Harriet.
Thank you, Kurt, and thanks for that lovely introduction. Thanks, everyone. And I realize I'm the last person standing between you and drinks, so thanks everybody for staying. So I'd been asked by Nick to talk about some of the more clinical investigations that are ongoing at Yale. So I chose to talk about treatment of tumors that are resistant to PD-1 inhibitors. My disclosures are listed below, but I also would like to add, grabbing a line from Ellie, that I'm also not an immunologist by nature. So just by overview of what I'm going to talk about, I'm really going to use metastatic melanoma as a model disease for immunotherapy. It's a disease that only affects 10,000 people in the United States per year, so much rarer than lung cancer and many of the other diseases. But for a multitude of reasons, I think this is the disease that's been studied the most, and of course it's the disease that I treat, therefore it's very easy to focus on it. I'll go over some of the advances of immune therapy that have been made in the last decade. Many of them were actually alluded to by Jen, but in case people walked in late, I'll go through them quickly, not to repeat though. We'll talk about some of the current challenges that we faced as melanoma researchers and new initiatives that are ongoing to overcome these challenges. So it's been a long time since the Cooley vaccine was administered in the 1890s to the receipt of the Nobel Prize that was mentioned many times today by Jim Allison and Tasuku Honju for discovery of CTLA-4 and PD-1 respectively, or PD-L1 respectively. And to go back to our world as melanoma oncologists, when I started doing this in 2002, it was actually really a dismal disease. Nobody actually wanted to treat it. We would get together at our annual meetings with a tiny little group of 20 people in the room. And I think this is exemplified by this table that was published in an article in the New England Journal of Medicine by Paul Chapman in 2004, in which he summarized all of the randomized trials that had been done up to that point in melanoma. And suffice it to say, it was negative trial after negative trial, it was after negative trial, but we were not discouraged. So since then, a number of regimens have been approved. Actually, it took many years until they actually got approval between 2002 and 2011, 2002 being the time that some of these drugs entered the clinic for the first time. So at the top, I listed the targeted therapies, the BRAF and MEK inhibitors, which I'm not going to talk about any further. And the lower part of the slide lists the immune therapies that have been approved to date. So you've got CTLA-4 antibody, Ipilimumab, PD-1 inhibitor, Nivolumab, PD-1 inhibitor, pembrolizumab, the combination of Ipilimumab and Nivolumab, and T-VEC, which is a herpes virus engineered to secrete GM-CSF. Jen showed similar slides to these. In our field, we talk about the tail at the end of the curve. So over the decades, there's always been a very small percentage of melanoma patients who actually did live for a long time, whether it was due to metastatectomies, in other words, surgical resection of distant metastases, or high-dose interleukin-2. We always had a 5 to 10% of patients who did live for a prolonged period of time, even before the modern era in our field. This slide also has been shown by Jen, borrowed from Alex Menzies at ASCO a year ago. We were all very excited about it, evidently. But even as early as Ipilimumab, when it was first approved in 2011, we knew that we were pushing that curve at the end of the tail up into the 20s. So at 2 years, over 20% of the patients treated with Ipilimumab were alive. And at 5 years, it was just below 20%. So we'd already made some improvement in the 5-year survival. And to move forward to the newer era, I've circled some of these in red. With the approval of dabrafenib and trametinib, that's the BRAF/MEK inhibitors, vemurafenib and colbimetinib, and pembrolizumab monotherapy, we were already at 50% 2 or 3 year survival, and maybe 30-40% 5-year survival. The newest regimen to be approved was the Nivolumab and Ipilimumab. At 2 years, we had a 64% survival, so significant improvement. This is a slide that was shown by Mario Sznol at ASCO in 2010 after the phase 1 multiple dosing of Nivolumab had been administered. So Suzanne had conducted a study prior to that, I believe, with a single dose of Nivolumab and had actually already seen responses with 1 dose. After that, Bristol Myers opened a second trial with multiple dosing. And I think none of us in the room had ever seen a slide like this before. Every patient with melanoma, which constituted around 30% of our patients, who had responded at that time remained in response. As you can see, the last column on the slide is time on study, the plus suggesting that they were still on therapy. So at that point, we already knew that we had a very valuable drug. So what do oncologists do when they have one drug that works a little bit, maybe 15% of the time, that's the Ipilimumab, and another one that works 30% of the time? We combine them, right? Back in the dark ages, we didn't even need any experimental evidence that this was a good combination. There was a single study that was done in an MC38 mouse model that showed that these two drugs were synergistic. But once these responses were seen in the humans, it was obvious that there wasn't enough time to waste. We needed to go straight forward to the clinic, and this is a credit to Mario Sznol, who went down to Medarex at the time, who owned the PD-1 inhibitor, and convinced them to do this study. So it was a 2-site trial between us and Sloan Kettering. There was theoretical rationale for doing this. So as everybody here knows, CTLA-4 is probably important early in the T-cell response when you get antigen presentation from the T-cells. It can interfere with the interaction between B7 and CD28. So you put a brake on that brake, and you'll get T-cell proliferation. T-cells will go into the circulation and into the tumor and microenvironment, where they will encounter tumor cells that express PD-L1. So this is probably old-fashioned, and this cartoon is no longer viewed as accurate, but that's what we thought was happening at the time. So with this lovely cartoon, we went straight into a phase 1 clinical trial, the design of which is shown in the slide over here. So Ipilimumab at 3 milligrams a kilogram was the dose that we knew the FDA was probably going to approve. Nivolumab was the newer drug, so you dose escalate that, and we kept the Ipilimumab at the FDA-approved dose. This is a very standard way of doing trials. Typically, you'll enroll 3 patients in each cohort, but in this particular instance, they allowed us to expand a little bit. So 14 patients were treated in the first cohort. Responses were already seen over there. Cohort 2, we escalated the Nivolumab dose by half a log. Cohort 3, we escalated it further to 3 milligrams a kilogram. And at that point, we'd only treated 6 patients. 4 of the 6 had very serious adverse events. So we decided to back off. We opened cohort 2A, which is 3 of Nivolumab, 1 milligram a kilogram of Ipilimumab, so the inverse ratio. 16 patients were treated on that cohort. We then sat down and compared cohort 2 to cohort 2A, and for no really good reason, we decided that cohort 2 was the better regimen, but we dropped the maintenance of Ipi because of the toxicity. We then expanded to another 41 patients in what we called cohort 8, because the other cohorts in the middle were never filled. And we dropped the maintenance over there, and that is the regimen that went into the phase 3 trial. This is a slide that I showed at ESMO, 4 years ago already. This is a swimmer plot. I think just to introduce you to this type of plot, it basically helps us understand the characteristics of the response. So the little black dots over here depict the timing of the response. So essentially, it's the timing of the first CT scan, which was typically done at 12 weeks. It doesn't mean that they hadn't actually responded earlier than that. A blue bar is a patient who remains on therapy. Red means they've had a toxicity and come off therapy. And as you can see in the early cohorts, we were taking patients off therapy very quickly. We were very anxious about the toxicities. The arrows at the end depict patients that have an ongoing response. So just as some examples, this is a patient of Mario's who received 1 dose, responded, but had a toxicity, never got treated again until well over 40 months, then had a recurrence, got treated again, had different toxicities, and remains disease-free. The one below that is a patient of mine who remains in response now many years later after getting 4 cycles and having a toxicity. So this is not an uncommon scenario in our clinic now, that we have these patients who were treated years ago, we stopped therapy, and now they just come in to see us every 3 months. And what are we actually doing to the tail at the end of the curve? So from this trial, we now have fairly prolonged survival data, and you can see that at over 60 months, approximately 55% of those patients are still alive. So again, significant improvement. So based on this, Bristol-Myers went ahead very quickly and did a phase 2 and 3 trial. This is the schema of the phase 3 trial. They basically did it very elegantly. Over 300 patients treated with dual checkpoint inhibitors, the same number treated with Nivolumab monotherapy or Ipilimumab monotherapy. And the results are summarized very briefly over here. You can see that over 50% of patients responded to Nivolumab and Ipilimumab. 44% or so to Nivolumab alone, and under 20% to Ipilimumab alone. So Ipilimumab is no longer used as monotherapy in the frontline setting, and the responses, once again, were very durable. So are we done? Can we all retire? I would say, unfortunately, no. We have to keep working until we get to close to 100% of our patients living for at least 5 years, if not longer. So what are our challenges that we face today? So many of these have been alluded to over the course of the day. Firstly, we need to reduce the costs. So just by way of an example, Ipilimumab and Nivolumab for 10 months of therapy costs almost $300,000. That's wholesale price, not including hospital markup, admissions for toxicities, CAT scans, visits, and the like. And to better select our patients so that we can only treat those that are going to respond, we need to have better predictive biomarkers. A lot of the talk today has been focused on that, so I won't go into it any further. We have to do better at controlling autoimmune toxicities, which occur in over 50% of these patients. It does appear that these toxicities are different than the standard autoimmunity that you see in the host organs. So, for example, autoimmune colitis induced by Ipilimumab and Nivolumab seems to be quite different than Crohn's disease or inflammatory bowel disease, and the same is true of many of the other toxicities. Most of them are reversible, but not all are, and sometimes they can actually be fatal. We don't know what to do with patients who have underlying autoimmune disorders. They were excluded from all the trials. CTEP will be sponsoring a basket trial, which will open over here shortly, in which we'll treat patients with various different types of autoimmunities, but regardless of their malignancy, with pembrolizumab, and hopefully we'll learn a lot from that. It'll be done in an organized fashion. Patients who can't get immune therapy or who never respond to immune therapies typically will go on to targeted therapies. BRAF inhibitors are good for the 40% of melanomas that have BRAF mutations, but what about the other 60%? And even those 40% will ultimately develop resistance to the BRAF and MEK combinations. Outcomes remain dismal for uveal melanoma and possibly less good for mucosal melanomas. Brain metastasis population is definitely a whole other challenge. Approximately 50% of our patients do develop brain metastases in the course of their illness, and the tumor microenvironment in the brain appears to be quite a bit different than other organs. But I'm going to use the bulk of my time talking about the 50% of patients who either don't respond to immune checkpoint inhibitors up front, or who initially respond and then develop resistance, and whether the resistance is developed over time or resistance is developed while they're off therapy, we still need new approaches for these patients. So what are we doing for this set of patients who are now resistant to anti-PD-1? So there are a myriad of trials ongoing at Yale and elsewhere. There are combinations with cytokine therapies. Examples include combinations with high-dose interleukin-2, with Nectar-214, which is a form of pegylated IL-2, IL-18, IL-12, interferon alpha, and many, many others. There are combinations with adoptive cell therapy regimens, combinations with other immune checkpoint modulators. We heard a fair bit about LAG-3 and TIGIT. Probably LAG-3 is the one that's the furthest along in development. So there are responses in patients who've progressed on anti-PD-1 alone, who then receive anti-PD-1 plus a LAG-3 inhibitor and do go on to respond. There's studies of TIGIT inhibitors, OX40 agonists, and many others. There are combinations with targeted therapies and chemotherapies, combinations with vaccines, and at present, actually hundreds, if not thousands, of these combinations are currently being studied in clinical trials. So when we try to develop a new regimen, we really have to think about the mechanism of resistance. And we've heard a lot about this today. I've mentioned a number of potential mechanisms of resistance that have been well characterized in the literature. So lack of T-cell infiltration or immune desert we've heard about, loss of antigen presentation, T-cell exhaustion, lack of PD-L1 in the tumor microenvironment or in the tumor is probably the one that's been the best characterized. You can have other immune co-inhibitory molecules on the T-cell, TIM3, LAG-3, etc. Or you can have other immune inhibitory cells such as MDSCs or Tregs in the tumor microenvironment that are essentially overpowering the ability of the T cells to kill the cancer cells. So currently we're looking at co-targeting the tumor-associated macrophages This is a big collaboration with the Keck lab. Actually, unfortunately, Sue Keck has moved to San Diego, but hopefully she'll remain involved. And Marcus Bosenberg's group has picked up a fair number of those experiments. We're using a CD40 agonist, CSF1 receptor antibody, and a PD-1 inhibitor, and I'll review the rationale with you over the coming slides. So Marcus Bosenberg developed a GEMM model for melanoma a number of years ago. I think the problem that we had in the field was that the B16 model that had been used most widely up to that point really doesn't harbor human or genetics that are relevant to human melanomas. So he developed this. The main model that he's used is a model that's driven by BRAF mutations, Pten loss, or CDKN2A loss. And once these mice form tumors, you can actually take them out and grow them in culture and select specific clones and regrow those. And so he's developed this kind of list of cell lines called YUMM cell lines, which stand for Yale University Mouse Melanoma. So YUMM1.7 is the one that's been most extensively used. So this YUMM1.7 only has 3 mutations, BRAF, Pten, and CDKN2A. So if you take the YUMM1.7 cells and you inject them into a mouse, tumors will grow out. That's the blue line. If you treat with anti-PD-1, absolutely nothing happens. If you irradiate those cells and generate a whole slew of new antigens, you do get some sensitization to PD-1 inhibitors, as depicted in the curve on the right. So YUMM1.7 grow just as well as YUMM1.7, but when you add a PD-1 inhibitor, it certainly retards the growth. So this is a model of some PD-1 sensitivity, but not complete sensitivity, because we're not completely eradicating the tumors. So Sue Keck took his GEMM model. And the first question that she asked was, well, what actually is the dominant cell type within the tumors? So these are data that were published by Sue Keck's group. The first author was Curtis Perry, who's now an intern in our program. It was just published recently in the Journal of Experimental Medicine. Now, it turns out that the dominant immune cell in the tumor microenvironment of these relatively resistant cells are TAMs, or tumor-associated macrophages. She went on to characterizing these TAMs by flow cytometry as well as single-cell analyses, and it turns out that you can see multiple subpopulations, not just the M1, M2, but there are other populations that don't seem to share the characteristics of either M1 or M2. An example is given over here. When you do flow cytometry by F480 or Ly6C, you can see there are 3 different populations. The ones over here, for example, the F480 cells are known to have higher PD-L1 expression. They don't secrete too much TNF-alpha, and these are considered the more M2-like types of macrophages. Then she asked, well, what happens if we try to modulate those macrophages with drugs that can actually either cause them to polarize or inhibit them? So going back again to the YUMM1.7 model, these are the control cells in black. Then if you treat with a CD40 agonist, which at the time was thought to primarily affect macrophages, you do get some retardation of growth. If you give a CSF receptor inhibitor, you get similar retardation of growth, and if you give the two together, you do see at least additive effect, if not synergistic effect. The macrophages within the residual tumors were then characterized, and you can see over here that when you give the combination of CD40 agonist and CSF1 receptor, you get a remarkable increase in this population up here, the Ly6C high, and a decrease in this population of cells that are F480 high. And again, these are the ones that express more PD-L1 and they secrete less TNF-alpha. She did some single-cell cytokine analyses. This is the principal components plot over here on the left, and you can see that the 3 different treatments result in 3 completely different residual populations of TAMs, CSF1 receptor inhibitor here, combo over here, and CD40 agonist over here. This is confirmed by the heat map, and when you hone in on the heat map and you look at what the actual differentially expressed genes are, that you see many of the suspects that we would expect to see. So CD40 agonist and CSF1 receptor inhibitor together, for example, result in a higher increase or greater increase in TNF-alpha, IL-6, et cetera, and there's also differential secretion of chemokines, as you can see in the little plot below. This therapy also affects T cells. When you give the dual therapy, the CD40 agonist and the CSF1 receptor inhibitor, you get an increase in the percent of CD8 T cells out of the total T cells, and you also get an increase in the PD-1 positive T cells. So it appears it's not just affecting macrophages, but it's also affecting T cells as well, this therapy. So everybody's trying to add something else onto the backbone of a PD-1 inhibitor. So the next question that we asked, and these studies were done by Bill Damsky in Marcus Bosenberg's lab, the next question was, well, what happens if we combine all of these things with a PD-1 inhibitor? So we're now going to large cohorts of mice, 15 mice per cohort over here, and you can see the triple therapy is depicted by the black line. When you give a PD-1 inhibitor, CD40 agonist, and a CSF1 receptor antibody together, approximately 70 or 80% of the mice are actually cured. They completely reject the tumors. The two doublets that contain CD40 agonists are the next good, or the next best, I should say, with approximately 50% of the mice cured at 60 days. The singlets and no therapy obviously fare much worse. On the right over here, you see the spider plots for the kinetics of the actual tumor themselves. Black is the PD-1 inhibitor alone. Most of the tumors do grow out with time. If you give a CD40 agonist plus a CSF1 receptor inhibitor, so just two drugs, you get most of the tumors do regress, but not all. And the triple therapy, you get regression of a larger number of these tumors. We have done some initial experiments in a RENCA murine kidney cancer model. It's not the greatest model. We don't think it necessarily reflects human kidney cancer, but this is what we have. Comparing triplet therapy to doublet therapy, here again we see that the triple therapy is better than the double therapy, and anti-PD-1 alone doesn't do very much. So going from the bench to the bedside, the question is, what could we do next? So we forged collaborations with Bristol Myers Squibb and Apixagen, and I don't know if Deepak Mistry is still here from Bristol. He was actually heavily involved in enabling us to launch the study. So Bristol Myers makes Nivolumab, which is a PD-1 inhibitor. They also make a drug called Ipilimumab, which is a monoclonal antibody to CSF1 receptor. Apixagen is a small company out of San Francisco that makes a CD40 agonist. Now, Bristol had given Ipilimumab and Nivolumab already to hundreds of patients, many with melanoma, not all with melanoma, but there was really modest activity in melanoma, particularly melanoma that had already progressed on a PD-1 inhibitor. But CD40 agonists have significant activity in melanoma, even when given alone, in older trials that were done at UPenn a good number of years ago. This is a very different CD40 agonist. So Apixagen had a very small phase 1/2 trial, I call it an oligocyte trial, of their drug together with Nivolumab in melanoma and lung cancer, which was initiated in 2017, and seeing that we had no experience with the CD40 agonist, which causes a completely different set of toxicities, we joined that trial. And we were thrilled to see that the very first melanoma patient that we enrolled on that study actually did respond. So this is a patient of mine who had been on pembrolizumab for over 3 years. He'd done very well. His tumors then started to grow. He's got lung lesions and pelvic masses, and after a couple of cycles of this combination, he'd had a beautiful response, and he remains in response. So CD40 agonists, when you add them to a PD-1 inhibitor, certainly can induce responses in patients who just progressed on PD-1 inhibitors. But with the preclinical data, we were able to then go on to design a phase 1/2 study of Ipilimumab, that's a CSF1 receptor antibody, the CD40 agonist, and we were doing this with or without Nivolumab. So even though the murine models do suggest that the triplet is better, we were very concerned about toxicity. So I don't think that anyone had ever given two macrophage modulating compounds together, and this made us a little bit nervous. So we started off with cohort 1 in our phase 1 study, where we give Ipilimumab at the full dose and the CD40 agonist at 1/10 of the recommended phase 2 dose. Then if that works and there are no toxicities in the first 3 patients, we can then expand both by adding Nivolumab on the left over here, and concurrently we dose escalate the CD40 agonist by a half a log. We can then go ahead and dose escalate the CD40 agonist once again by a half log, while adding Nivolumab on the side. So the darker blue little the squares over here are the triplet cohorts. The doublets are in light blue. And this is a study that I wrote together with Sarah Weiss, who I think is over here. And the trial has actually started. Once we determine what the recommended phase 2 dose is, we will then be able to open the study in 3 different cohorts. So these 3 cohorts are essentially the same as 3 different phase 2 trials. One's melanoma, one's renal cell, and one's lung cancer. And the design of all the different cohorts is very similar. We built in multiple biopsy time points and blood collections, so I think that we're going to be able to learn a hell of a lot from this trial about the biological effects of CD40 agonists and CSF1 receptors in these patients. So just to give you a couple of updates on the phase 1 trial, we have filled cohorts 1, 2, and 3. So far, we've got 7 patients with renal cell, 2 with melanoma. We did have 1 toxicity on cohort 2, so we're now expanding. Overall, we're seeing toxicities that are mostly characteristic of the cabiralizumab. So we see a lot of periorbital edema, elevated CPKs, mainly because of Kupffer cell injury, elevation in AST and ALT, as well as some fevers and cytokine release types of toxicities in the first 48 hours. We don't yet know the recommended phase 2 dose, but hopefully we'll get that over the coming months and be able to expand in the 3 diseases. We have collected blood samples on some of them. Eric Meffrey has helped me with some early flow cytometry studies, and what we're seeing is essentially effects on multiple cell types, B cells, NK cells, and monocytes, and this is all in the circulation. So we do see changes in Tregs, not so much in the T cell number, but we do see an increase in memory T cells as well as a decrease in Tregs. So more to come. These studies, these cytokine studies are very preliminary, and they need to be validated in additional patients. So I'm just going to conclude over here that despite progress in treating advanced melanoma patients, particularly with anti-PD-1, not all of our patients respond, and we still have a lot of work to do. Multiple mechanisms of resistance have been described, including an abundance of tumor-associated macrophages and a paucity of T-cell infiltration. And these can hopefully be harnessed to develop newer regimens for melanomas that are resistant to PD-1 inhibitors. So I think we're actually just at the beginning of our road. Co-targeting the innate and adaptive immune systems with a CSF1 receptor inhibitor and CD40 agonist does result in better anti-tumor effect than either one alone. It also increases CD8 tumor content in animals. And then if we treat mice bearing anti-PD-1 resistant tumors with these drugs, either just the 2 of them or in combination with Nivolumab, we do get enhanced activity, and it appears that the triplet is superior to the doublets, including the doublet of the CSF1 receptor antibody and CD40 agonists. These findings have been confirmed in a RENCA model, although the percentage of mice with tumor rejection in the RENCA model is lower than melanoma, but that's actually fairly consistent with what we see in clinical practice, whereby renal cell carcinomas are way less sensitive to any kind of immune therapy than melanoma. So clinical trial testing this finding has been initiated for patients with these 3 tumor types, melanoma, renal cell, and non-small cell lung cancer. So I'll stop over here and just acknowledge all my collaborators. So Sue Keck, Marcus Bosenberg, and Bill Damsky have done the bulk of the preclinical work. Curtis Perry did the initial studies that justified the trial, and Sarah Weiss is my clinical colleague who's helping me with the clinical trial. We've got a very big clinical research team. Our pharmaceutical collaborators are key to this project, and of course there's funding from multiple sources as listed below. I think with that I can take questions.